Yeah. Hello, friends. So this is just a snippet review on. I'm sure you must be guessing what is COE. So it's a center of excellence. So the context setting for this is now with so many new hospitals that are coming up, especially in a city like Bangalore or in any urban city, so many corporates. So there is a lot of transition of people from one place to another. Stay, claiming sort of a huge sort of a claims that they would be running a center of excellence. So this is the word very commonly used by some of the clinicians uh, trying to claim certain big things that we would set up a center of excellence. So it is good for intensivists to understand what really constitutes a center that needs to be called a center of excellence, because it's a very easy word to use that okay we run a center of excellence, but are there any defined criteria? It's a snippet, so I will just tell you the components of it. So there is, I wouldn't say there is a clear cut sort of an objective markers, but there are certain 8 pillars which are meant to be in place to call a center of excellence. So this is more pertaining to intensive care. So it's just one slide which I will show you different dimensions of it. And even for the trainees, DRNBs, when they take a seat in an institute, and I would see that they would take in various hospitals out of some ad hoc choices people would make. But one really needs to understand, even for advanced trainees in intensive care, what really constitutes a place to be called center of excellence for them to embark on their journey to further the science of intensive care. So that is what we look into. So it has around 8 sort of a salient pillars. And this is important for all the healthcare leaders also to know before they employ people as to their understanding of what you call it as center of excellence. So when you talk about center of excellence, there, as I said, there are 8 units. The first thing is any place that you go as a center of excellence. So we'll talk more in ICU. If someone is joining an intensive care in a hospital, so there should be a vision in that place as to what is their trajectory and what is their sort of a roadmap that they have. So there's some sort of a vision should be there, and whether that place has a feasibility to evolve as a center of excellence. That is also terribly important. So even if someone is putting a stake of claim that they would be putting up a center of excellence, so one should really have a insight into whether there's a feasibility for that place to evolve as a center of excellence. That is important. And this is very important, whether the patient volume is good enough and whether that center is ready to evolve and progress as center of excellence. So there should be adequate patient input into that center and the feasibility and a vision from the leadership of that hospital, whether they would want to evolve that center into center of excellence. So this is the basic insight criteria. So there should be a primordial insight that should be prevailing before they embark on the journey of putting up a claim that the center of excellence is going to happen in this. So that is something that needs to go. Second, most important, which is terribly important, which not necessarily many centers may be following, although they may see it is very easy. A clinician or for anyone may say we are following standard protocols, we are following evidence based. But honestly, friends, I can tell you, I can put my hand on my heart and say it is not that uncommon to find most places not necessarily following the best practice guidelines or sound evidence-based medicine. So we would be deviating very often. So having a robust protocols across the board and having a management plan in a sound evidence-based medicine, sort of following evidence-based principles with the current available evidence is something that defines a place as heading towards fulfilling the criteria for center of excellence. So the best practice guidelines and the standardized protocol for most common diseases that are treated has to be put in place, and every decision that is taken in this place should be justified by evidence. So tell me, how many of you would think that in your practice that each and everything that you are doing is substantiated by evidence? For me, the answer is a big no, because I see even in my hospital many a times that there will be a deviation. So I think that is something, it has to be sacrosanct to a place that should be called center of excellence. And obviously, why we do this? Because science has shown time and again by following a rigid best practice guidelines in a protocolized way and following and adhering to the core principles of evidence. So you would be putting up a good quality sort of a clinical care that is expected out of that center. And the third most important thing that has been attributed to claim a center of excellence, which is also important. This is more so pertinent for trainees, that that center should have all the infrastructure and technological advances that are expected out of that specialty. Like in intensive care, you cannot say I will develop a center of excellence without having a portable ultrasound or without having a cardiac output monitor, without having a bronchoscopy in place, without having a standard 6-channel monitors connected to the patient, or without having a portable X-ray in that hospital, without having an MRI or CT in that hospital. So the list goes on, without having ECMO facility or anything for that matter. So the technological sort of a underpinnings of that place should be in place to substantiate. So they should be on par with the expected technological gear up or the capacity building that is expected out of that place. And to see reference, so all these have references, although this is a snippet review. mm, so it is very clearly mentioned that electronic based record system and the digital footprint of that hospital has to be there at this point of time to call it center of excellence. So if any hospital is fully pen and paper at this point of time, it is very hard to say that they're heading towards claiming it to be center of excellence. So there has to be a digital footprint, a very strong digital footprint, very strong electronic medical record in place. The reason for that is because the ability to retrieve the records and making it seamless is a lot more effective with EMR. So electronic medical record and the digital sort of advancements have to be put in place. And the fourth point, which I think today, if you ask me, is there any ICU center of excellence? I would be very hesitant to say if at all any ICU is center of excellence. The only reason is because the current evidence suggests that every ICU has to be digitally connected with tele ICU services, and integrated network is what has been emphasized, friends. I think this is what I want to make a claim in this particular snippet, that the way, and please refer to the video where I had made about the future of ICU in next 5 years. Even there, I have re-emphasized that tele ICU services or digitally connected ICU to all other different sort of a for the networking so has to be put in place. So that is something. The integrated network is what has been spoken about now. So that has to be put in place. So the tele ICU and digital connect of ICU to any other places that you wish to monitor has to be put in place, or it has to be equipped with a facility where from intensive care, which acts as a command center, you should be able to follow through or monitor vulnerable patient in other places, or in an integrated network centers has to be put in place right now as I'm speaking, to call that place as center of excellence. So this is a message to all our future health leaders. We need to adopt this. If we are not adopting this, I think we are falling short of calling ourselves as center of excellence. And every place, and even this, friends, when I made a claim that no ICU at this point of time can brag itself to be called a center of excellence, because not necessarily they will fulfill all the criteria, because the research, because you tell me, I mean, any department tells they're running center of excellence, then they need to tell us what is the research projects that they're doing, what are the publications they're doing, whether there is some innate effort from their side. Because I hear people coming to me from other departments telling, they are running some three departments in three different hospitals and they are the center of excellence. I don't agree with that, because if you are not produced one paper from your department and you stake a claim saying that we run a center of excellence, I think that is superfluous. So you need to say in a year how many. I am telling you, in my unit, we at least do 8 to 10 publications. That is less, but still we do it. And key performance indicator. And this one has to very honestly tell oneself whether key performance indicators at ICU levels is someone doing it in a very diligent way or in a very systematic way. So I know there is a quality cell. Most corporates have this quality cell, and they're completely disconnected to the departments, and they may be doing for the sake of NABH accreditation or JCI, but it should be department driven KPI. That I would differ. I don't think anyone is doing this. Department driven systematic key performance indicators or incorporating quality indicators and auditing their quality indicators in a systematic way at regular intervals and showcasing that they are within those standard benchmarks that has been put in place or getting better than those benchmarks is the way to say that you are running a center of excellence. So that is very important. And this is to ensure and maintain best practices are sort of incorporated and are practiced in day to day. And so we finished four pillars. The fifth pillar, the center of excellence, as per the current literature, suggests that you need to have highly trained professionals in any department to call it of center of excellence. I see departments running with some BMS or homeopaths, and you can't call that as a center of excellence. So if you have a department and you want to call it center, there should be highly qualified personnel in your team who are qualified. When I say qualified, just because someone has worked in intensive care for 10 years, 15 years does not make them as fully highly qualified. So we need to have individuals who have gone through structured training program, have attained qualifications, and are progressing in their career pathway by doing sort of a good academic work is something that qualifies them. So we cannot have any department with a poorly qualified team and with one person who may be qualified calling itself as center of excellence. So that is also terribly important, and the team should constitute highly trained professionals with special areas of interest in each individuals to call themselves as center of excellence. And this is important. Again, it's an extension of what I have said. The whole ethos of center of excellence, we cannot call a place a center of excellence unless it is working on a hub and spoke model. So a center can be called center of excellence if it is hand holding other sort of a smaller places and homogenizing the care in the other small places by integrated network. That is a buzzword. You need to have an integrated network hospitals in your domain, and you handhold them and raise the standards of care there, homogenize the care, which means you are meant to be mentoring the other units to call yourself as center of excellence. If you are not mentoring other units, you cannot call your unit as center of excellence. And I see a fashion, people saying I'm running 3 units, 4 units, but that is not the way it works. There has to be one center of excellence, and there has to be handholding and mentoring of other units to match to the center of excellence is the way. So collaborative networking, integrated networking is the way to call a place as center of excellence. And that is something that needs to be put in mind. And the seventh one is whatever care pathways that you determine or a process driven pathways, it has to be patient centric. So that is something which I think is more subjective. So everything has to be driven to absolutely make sure that the patient is benefited from all the processes that you have put in place. And that is something that needs to be, that is emphasized. And one should have all the safety norms and the safety protocols to obviously protect patient interests. And you have some sort of an accreditation process. I'm sure now it's a fashion that every hospital goes through NABH, JCI, but it's a good way that is being suggested because your accreditation process basically puts a tick mark to all the checklists that you may have, the safety norms and the whole patient-centric care that we have. Because the whole NABH, if you look into all the checklists, it is to absolutely ensure that patient is kept safe and we mitigate and minimize all the sort of errors that may harm the patients is what essentially they look at. And all this is enshrined in continuous teaching and continuous upskilling and continuous sort of a academic endeavors that one puts in place for upskilling and improving the care processes is what has been referenced. So, and the last eighth bit, so that is the seventh bit. So basically, we can, all these are mutually inclusive, and obviously, all this has to funnel up to improving the finances. So that also is enshrined in Center of Excellence. So Center of Excellence should be financially sustainable, and operationally it should be sustainable. So operational superiority should keep happening, and it should be financially sustainable. And Center of Excellence should showcase how effectively the resources are optimized and they are not sort of put in disarray. So effective good resource optimization also defines good financial sustainability, and there should be obviously an audit of how well that center is doing financially, whether it is, because you can't claim Center of Excellence if the unit is running in losses. So even financial well-being defines Center of Excellence. And Center of Excellence is also is reflective of how effectively it is marketing itself, showcasing its performance indicators, and creating noise with good marketing strategy is what defines Center of Excellence. So friends, so if you remember this picture, I think this pretty much summarizes the key elements. There are 8 pillars of Center of Excellence. So very quickly to summarize, it is first try to look into the whether there is a feasibility of the place, and following sound evidence-based protocolized medicine with a good teaching, with good sort of a continuous professional development programs that are happening. And the third thing is to have good technological and structural sort of innovations that are there in the place, which are state of the art, and most importantly, a good digital print and tele ICU. That is a new thing. I think every hospital now, which or ICU, I will talk about ICU, has to have tele ICU connectivity. And of course, all of you have keep hearing the words quality indicators. There are 120 quality indicators, of which 20 are considered bare minimum to call itself an ICU, which I have spoken in another video. And that unit has to be performing research. Highly qualified professionals should be there, and integrated network. So the Center of Excellence should be able to handhold other units and work in an integrated sort of a way, in collaboration, in a collaborative and integrated way with the network hospitals. And it should be patient centric with compassion, empathy, with safety kept as a primordial, and it has to be financial sustainable. So these are the 8 elements, good for all the trainees to know, good for every intensivist who wants to move as an ICU director or a cluster head or so on and so forth, to understand what are the elements, nuances that defines a place to be called as Center of Excellence. So that's about it, friends. So thank you one and all. Request you all to submit valuable work to Journal of Acute Care. And of course, you can visit my website to read to this lecture. Thank you. Thanks. I think this is a nice word. The secret is there's no secret. So for Center of Excellence, consistency or intensity, progress or perfection, and fundamentals or fates over and over again. So that's what makes the center an excellent center. Thank you. Thank you, friends.